everyone. This is the Shelbourne Knee Center podcast. This is Dr. Benner, and I'm here with my co-host Scott Bauman for another episode tonight. If you'd like to catch any of our previous content, you can see our podcast on any available podcast avenues that you usually get them from. If you like what you hear, leave us a 5-star review and leave a comment for those that come behind you. If you'd like to find us on social media, you can see our Facebook and YouTube pages for the Shelbourne Knee Center podcast. You can find us on Twitter and Instagram at the SKC Podcast. And if you'd like to email us, you can email us at the skcpodcast@gmail.com.
Before we get into tonight's episode on patella fractures, we want to direct you to our previous content. Today is going to be our 56th episode, so we have 55 previous episodes that you can check out, most of which are clinician-focused, but we also want to direct you to the Patient's Place episodes that we've been putting out in the past couple months. These are more patient-focused, more educational resources for patients. We've done episodes on osteoarthritis, knee replacements, ACL graft choice, MCL tears, PCL tears, you name it. So go ahead and check out those episodes, and if you're a caregiver or a clinician, you can direct your patients to those for more education.
Tonight, we're back to having a guest on to talk about a knee topic, and a guest that I've known for quite a while since my residency training when I was, I believe, a fifth-year resident. He was an orthopedic trauma fellow at the University of Tennessee in Memphis at the Campbell Clinic, where I was lucky enough to have trained and got to learn from some of the best people in our field. So tonight's guest is Jan Szatkowski. He is an orthopedic trauma surgeon at IU Health here in Indianapolis. He is the director of orthopedic trauma at IU and is also an assistant professor of orthopedic surgery at IU, at the IU residency program as well. So Jan, thanks for joining us tonight. We've been talking about this for a while and finally found a time to get it done to talk about patella fractures.
Yeah, absolutely, Rodney. Thank you for the invite, as well as Scott. Looking forward to this. Thanks for making this happen. And yeah, it was a great time back in Memphis in 2010. I was reminiscing with Scott. So we both come a long way and found each other back in Indy. So
gosh, I hope so. I hope we've come a long way since then. Very good. Well, tonight we're going to talk about patella fractures. And, first from the very beginning, I don't do a lot of patella fractures. I get maybe one or two of these a year in my mostly elective knee practice, which I'm sure you see a lot more than that. So I wanted to cover this topic tonight. I think it'll be a good one for those out that are taking care of community trauma. This is something that you're not going to necessarily have to be at a high level trauma center like you're at to be able to see. You're going to see these in smaller hospitals and people coming into clinic to see us with these as well. So let's just start from the very beginning. What are you looking for on history and physical exam when you're taking care of patella fractures, or review for maybe residents or medical students who are listening, as well as people who are seeing these out in the community when they first come in? What kind of things you're looking for?
Yeah, absolutely. So just with, any type of fracture, I'm always looking at this is not only a bony injury, but a soft tissue injury. So many of these patients will have difficulty weight bearing, with their knee. They'll also have the inability to flex and extend their knee. So, we're looking at their extensor mechanism. They will oftentimes come with a swollen knee and pain around their kneecap. When we say patella fracture, we're always talking about the kneecap. So those are kind of the typical things that I'm seeing with the patient. And, they can also have some other injuries as well. So I'm always looking at their entire extremity and, seeing what else they may have injured when they've fallen, whether it be a trip on ice or some type of direct impact against we see it sometimes if they fall on their knee, or against a dashboard, for example, if they were in a car accident.
Yeah, that was going to be my next question. The normal mechanism of injury. I think the majority of these are falling on a knee. And I guess from my perspective, seeing mostly elective knee problems in the office, I'm always kind of surprised at the things that people get told either in emergency departments or by primary care physicians or athletic trainers, things like that, of things that the diagnoses that they give patients from a fall directly on the knee. I had a fall and it hurts in the front of my knee. They think I might have a meniscus tear, or they think I might have torn my ACL or things like that, which we know is pretty uncommon. So, talk a little bit about specifically falls directly on the knee. And for me, there's only 3 or 4 specific diagnoses that you see in that particular with that particular mechanism of injury.
No, I agree. I think, this is sometimes as well, just, looking at the knee and examining the knee. I think you and I will see knees very often and, palpate them or, touch the kneecap, and they'll have direct pain over that. And I think that's much different than someone who has an acute ACL tear or a meniscus tear. They're not really having pain directly on their patella. Mm-hmm. Sometimes you can actually feel a gap when you're pushing on that area, just like you see if you saw like a quadriceps tendon tear or a patellar tendon tear. But this is more of a bony gap as opposed to a soft tissue gap.
Yeah, and in that situation, I'm thinking about, did they tear their PCL? Did they fracture the patella? Those are the main ones. And if not, then do they have any kind of cartilage damage to the back of the patella? Is it just a bone contusion from falling directly onto the tibia or directly onto the patella? And that's about it. So I think that's one thing that hopefully we can get information we can get out there for clinicians, that if somebody has a fall directly on the knee, we can really narrow in on just a few diagnoses that the patient might have, and of course, patella fracture being one of them.
No, absolutely. And I think, what you just mentioned, I have seen a few delayed ones that come to the office because they get put in a knee brace. They're thinking it's an ACL, and then they see us like in our, walk-in clinic,
10
maybe
days
a week
later.
or two later.
Yeah.
And you're like, oh, well, you're at the right place, but maybe, wrong diagnosis. So,
Or at the wrong time.
anytime you have pain around the knee, I recommend an X-ray, right? People are like, why are you getting an X-ray, right? I need an MRI, but this is one where you need an exam and you need an X-ray as soon as you can.
Now, you did mention some imaging earlier, MRIs or X-rays. Can you walk us through specifically about what you would get when you see the patient acutely?
Yeah, so acutely, I always, start with an X-ray, an AP lateral of the knee, and many times I have gone to getting if there is a fracture that I see in the patella, I have been, very, I would maybe not aggressive, but very, very often we'll get a CT scan of these injuries now. X-rays can underdiagnose and not really show the full extent of the injury here. And as, Rodney mentioned, you may have some other type of injury over even the proximal tibia or the distal femur. So the tibial plateau or distal femur, there can be sometimes another fracture that's being missed, but also just because where the kneecap is on the knee, there's going to be overlying soft tissue and other bony structures. So I think a CT is a must almost in all these injuries now. And, I'll get one, just for preoperative planning for most patients.
Yeah, I'll be honest, I don't know that I've ever gotten a CT on a patella fracture that I was going to fix, but there were definitely some times afterwards that I wish I had. I can tell you that. I think sometimes the amount of comminution of the patella is sometimes a little bit underwhelming on plain X-ray. I definitely agree with you there. And sometimes it looks like, oh, this is just two fragments, pretty easy reduction, pretty easy thing to get fixation in. And then you find out, especially in the coronal plane, in the sagittal plane, where it was kind of tough to see splits between anterior and posterior parts of the patella. You put that first screw in and it kind of collapses and things start to split, and you go, where the hell did that come from? I didn't see that coming. So maybe that's something I need to add to the repertoire there a little bit. But for me, I'm usually a little more of a purist when it comes to fixation techniques. I'm still kind of stuck on cannulated screws plus minus wire for these, and I know that that isn't necessarily the state of the art when it comes to patella fractures. So talk about those kind of established techniques, those more historical techniques, maybe of, maybe even before I trained, you fixing these with K-wires through the patella and then wires, and then the move to cannulated screws with or without wires. And kind of, as we get to 2025, any problems we've had, any kind of a review of established fixation techniques, as well as some potential problems with them.
Yeah, I think there's a whole spectrum of fixation techniques, and I think all of them can be valid even in today. You're going to talk about state of the art. But, if we go back historically, we used to just fix these a lot of times with K-wires and a tension bend technique. Over the top of the patella, you had, you place two K-wires from proximal to distal or distal to proximal, and then you do a figure of 8 tension band technique. That worked well, but especially for transverse fractures. In comminuted fractures, not so much, because you're relying on the compression of the fragments. And so, people started looking for different fixation techniques, and kind of we've then progressed. And like you mentioned, instead of using K-wires, because the times you have to remove K-wires is extremely high when you use it for tension bend, whether it's in the elbow like olecranon, whether it's in the patella or anywhere else. So people then started using cannulated screws, and maybe
Real quick
use.
before you go on, I once had a lady that came and saw me that had one fixed with K-wires and a tension band, and she had a small area that was prominent. So we went in, took out some hardware, said, now this broken hardware is out, you're going to be fine. And then a couple months later, she was back. Now this piece of hardware has moved. Like, I didn't take all of it out. I just took the offending pieces out, and I operated on the lady I at least twice. And I think she even had some pain afterwards that I was just shocked at how much hardware there was everywhere. And I thought, just go in and take out the pieces that I absolutely have to. And it was just kind of a mess. I didn't even fix it, but then I ended up operating on her, I think twice, taking out little fragments of hardware that was, was a pain.
And I think that's why people then moved on from that, because either the K-wires would have to come out almost all the time, and or the tension band that was made of metal would break. And if it always broke 100% of the time, and patients don't like seeing broken hardware, whether it's symptomatic or not, it becomes optically symptomatic.
No doubt.
So then people went to cannulated screws, and they would, we still use those, obviously, especially for transverse fractures. So more simple fractures, a simple fracture plane, and people will put wires through the screws instead of K-wires. That has also then progressed where people now use sometimes fiber tape, fiber wire, some type of suture to tension, but it's harder to tension suture, as you know, like it's easier, to tension metal, but suture doesn't work as much. But there have been some biomechanical studies that show it works, and I've used it and with success. And I think now we're progressing, like if you talk about 2025, whether plate fixation is the way to go. And there's several different manufacturers that make plates, and they're small plates, bigger plates, like larger size, like circular plates, that different shape, a star plate, you kind of name it. And I think that's kind of like the 2025. It's been the trend for a couple of years, but I think now people will talk about, should you plate a patella or not? And there's pros and cons to that. I mean, there's definitely more dissection that you would usually use. They're pretty thin plates, so they're like 2-4 metal, so they're very thin. But there's definitely more dissection. Anytime you have more dissection, there's more potential soft tissue irritation. But for those small pieces that you mentioned, where you have like the splits in the sagittal plane and coronal plane, you can capture those fragments. And so I've been using it probably in the last few years. I will more often than not use a plate to fix patella fractures. I'm more confident in the fixation, and the plate is actually a tension band itself because it's on the anterior surface of the patella. So you're recreating. You got still like the AO dogma that you need a tension band. Fine, we're satisfying the AO gods back in Europe. We're using a plate though.
Yeah.
The one thing that I would say has been a more change for me in the last few years is, like I said, this is also a soft tissue injury. I will back this up with some type of suture fixation through the patella and the quad tendon, almost like a cerclage or something else, to try to counteract some of the forces. There's a lot of force across that patella joint when you're bending and your knee and straightening it. So I would say that's one of the big changes too, is soft tissue fixation with bony fixation.
How much difference have you noticed in your patients post-operatively since you started using plating of patella fractures? Is there anything that you felt like you struggled with before you started to use that you don't see as much now that you've switched mostly to plate fixation?
Yeah, I'm more aggressive with early range of motion. So I still let them weight bear immediately when they're fully extended in a knee brace. But at around 3 to 4 weeks, basically when they get their sutures or staples out, I start range of motion at that time. And I think that's the plate fixation as well as the soft tissue fixation that I'm doing. I'm much more confident because, it's hard for a patient to like walk. I tell them to walk like a peg leg Pete, with a straight leg for, 6 to 8 weeks, then start motion. So I've been 3 to 4 weeks, and now I start motion, and I've been much more satisfied with the patient almost self-directing their motion, slowly in a brace, but going a lot faster than I used to in previous years.
Now, Jan, speaking of postoperative rehab, we were sharing on the call before we started that I was actually a physical therapist before I got onto the research side. So I'm always curious to talk to surgeons when we're talking about different surgical techniques. What does your postoperative rehab look like? You said you had mentioned with plate fixation, you're maybe leaning towards a little bit more of an early range of motion allowance. But in general, can you just walk us through what your typical rehab plan would look like for these patients after surgery?
Yes, this is a great question because this is a big thing where I think you really have to spend time with the patient preoperatively so they understand what's going on postoperatively. And for me, it's, I keep them straight in a brace. I use a hinged knee brace, locked in extension when they're mobilizing, and they can, bear full weight after surgery. I usually wait a day or two. Technically they could do it right away, but I want them to get quad control and avoid any type of fall or mishap immediately. So after that's done, then I start at around 2 to 3 weeks. I'll start early range of motion of their knee, usually from like 0 to 30 degrees, and then progress about 20 to 30 degrees every 2 weeks after that. On some patients who have a very, I'm very satisfied with their bone quality and repair, and now that I add that soft tissue repair, I almost let them unlock the knee brace and start doing both, start doing passive at that 3 week mark, passive and, 40 to 60 if possible. I'm much more confident. Usually pain is limiting them and they have an effusion. So, that's, I don't have to like tell them like, don't do it, because as long as they're compliant, that kind of is, they have some self-limiting things going on with their knee still.
Yeah, I'll say I'm a little bit more aggressive probably than most people with regard to range of motion. Some of that may be because I see these out in the community that are maybe a little bit lower injury than what you see at a trauma center. And because maybe I don't see as many of you, so I don't see as that what people can how people can mess them up if they don't listen to us. But do you no, I always, after we're done fixing a patella fracture, if I feel like I have reasonable fixation, I'll bend the knee and see kind of how far I'm comfortable bending the knee intraoperatively, and set that as kind of an early limit for them. So if I feel like I can get them, sometimes it's 30 or 40 degrees and you think, wow, that's starting to feel pretty tight even at 30 or 40 degrees. Sometimes it's 90 or more that the knee feels like it can pretty easily go to. And then I'll set that as kind of an early goal or an early limit, I guess, to have the therapist say, let's show them how far this is. We utilize a yardstick that we put at their heel at the end of the yardstick. And we'll, if we want to limit them at 60 degrees, we'll go to the opposite knee, put the foot at the end of the heel at the end of the yardstick, bend it up to 60 degrees, measure it and say, okay, well, that's X amount of centimeters. On your other side, when you're doing your bending exercises, you can go up to this limit, and that's as far as I want you to go. If you can't get there, you can't get there. But if you can get there, even if it's easy for the early time period here, that's what I want your limit to be, because that's what I felt like in the operating room. I felt good about my fixation in. So, and I'll do the bracing really just with weight bearing. When with weight bearing, I have the patients do it with the knee out straight. But we start working on quad control relatively quickly. Quad sets, especially just for quad activation. And pretty quickly, as soon as I can get them to lift their leg, I allow them to, even early on after surgery. If I get rock solid fixation, a good retinacular repair, which, as you know, is often a big part of this as well, is getting that retinaculum solidly fixed. And I think it's pretty uncommon that we're going to cause any fixation problems by just letting the patient do a straight leg raise if they can do it comfortably. So I'm pretty aggressive early on with them working on leg control, even outside of the brace, as long as they're not weight bearing. So, I think over time, especially if if we're using plating and we feel like we're getting even better fixation with a lot of hardware, I think we can afford to maybe be a little more aggressive with that even.
Yeah, I agree with that. I mean, that's some very good points. I think you see a lot of other knee surgery, right, with the total knees and so forth. So I think that's an excellent point, because that's why we're plating it, right? We think
Absolutely.
It's better fixation. So in essence, maybe we should be letting them, rehab a little bit faster. The most common, I guess, mechanism that I see that where I'm seeing the patient back, or it's a common reason, excuse me, is, and with failed fixation, is not because of their original fixation, is that the patient had another fall or trauma. So my big thing after these patients is like, or, after this type of injury and surgery is you cannot fall. Like I tell that to the
falling's
family
against the rules. Yep.
that is when they come back. I mean, you can put a plate, you can put a tension band, you can put cannulated screws. You fall, it's gone.
No doubt about that. Regardless of what we do fixation wise, if they have another injury, that's always kind of out there. No doubt about that. Yeah. And it's I do think the perspective is a little bit different when from the trauma world versus the sports medicine kind of reconstructive world that I have more time in, is just thinking about function versus healing. I'm always thinking about function. I feel like fracture surgeons are thinking a little bit more about healing, and somewhere in the middle there is the right place. And it's just hard to figure out exactly what is the, how far we can push to try to gain early function versus how far how can we prioritize early healing. So I try to have that conversations with patients early on. Like, I feel like I could go farther than this. Can I push farther than that? You probably could, but you know what? For right now, we got to make good decisions here in the first month or so, as this is really having some early healing before we really press it anymore. So, one of the ones that I think is particularly tricky are these distal pole fractures that we see often in elderly people, often in people who have a lot of osteoporosis, and it can be relatively comminuted. A lot of fragments of that distal pole. Those can be particularly tricky. So, what are some tips and tricks you can give to our listeners about how to handle distal pole patella fractures?
Yes. So you're right. These are a little bit trickier just because there's less bone. So when there's a distal pole, there's usually less bone to fix. So there's not like a great plate that you can use because it's a very small fragment. So I've gone back and forth on this, and a lot of it just depends on what type of fixation I can get of that distal pole to the main fragment of the patella. So I've done, sometimes using almost like a hook plate, making a cell, and like hooking that part of the patellar tendon, because usually that's still pretty good quality, back to the bone, back to the main part of the patella proximally. I always back these up with suture, no matter what. This is where I will tie this into the quad. So if it's a distal pole of the patella, I'm doing a cerclage into the quad tendon as well. And I tend not to be aggressive with the range of motion here. I hold them back a little bit and almost treat them like a patella tendon tear. The caveat is sometimes I'll do an excision as well. So if the bone starts in some of these elderly patients, geriatric patients, their bone quality is poor, and I will just remove those bone fragments, fix this as a patella tendon, and then do that type of rehab protocol that I do for patella tendons. And move on from that. I don't fix the fracture then, because you could put plate screws, it doesn't hold, and like you said, you want function, and I think taking out that much of the patella usually does not matter in terms of function long term.
Yeah, I tend to agree. I feel like of the patella, of the distal pole fractures that I've done, I find that the majority of them, I tell the patient I'm going to fix it with screws and a wire, and the majority of them I end up excising and fixing like a patella tendon rupture. One thing that the way that I treat patella tendon ruptures, I actually use a Dahl-Miles cable through the patella and through the tibia to protect patella tendon ruptures. I do that 100% of the time. I put them in a brace just early after surgery until they can lift their leg and have good leg control, and then I let them do unlimited flexion even really early on after surgery. I mean, day after surgery, we're letting them flex as much as they can because the cable has pretty solid fixation. So in distal pole fractures where I've ended up excising the patella, I'll often tell the patient beforehand, if we can't fix this, or even if we can fix it, even if we can get those inferior pole fragments to heal back, I'll a lot of times back it up with a cable and allow them to move from the very beginning. Now, the caveat to that is that we got to go back and take the cable out because the cable can't stay in forever. But in my opinion, that's a 5-minute operation, very, very limited complications associated with taking the cable out later, and the functional benefits that we get from being able to move them pretty aggressively early on, both for a patella tendon rupture and for a distal pole patella fracture, I think are worth the extra operation. So that's something I probably need to write up and get out in the literature, because I just think it is a give and take, but it's one that I think is worth it.
Yeah, I've also done something similar, not with metal, but with fiber wire. Mm-hmm. And I've had, I think, good success with that. And I will do that, especially if poor bone quality, or revision type of situation. I have done that just to try to protect the repair, and I've been happy with it, with the fiber wire fixation of it.
Yeah.
Going back to the postoperative rehab for this, specific to the distal pole injuries, you mentioned that you are a little slower and a little more conservative with the flexion compared to your typical patella fracture we're talking about at the beginning of the episode, where you're a little more aggressive, especially when you're using plate fixation. Are you seeing these patients eventually get that back, or are you more concerned with function at that point, even if they have a little bit of a flexion deficit long term?
Yeah, so thankfully, I have not seen too many, issues with motion after these types of injuries. So for me, even if I've delayed them a couple of weeks, so like, I would usually wait about a month for like a patella tendon to start moving them. I have not seen issues with motion long term. They are slow in the beginning, but I almost want them to be slow because it's like I want it to heal. And I'm worried usually about their soft tissues because, osteoporotic patients who many times are having these fractures, their soft tissue is not the best either. So I'm just trying to weigh it. Like when I see, and it's my selection bias, if I see a failed extensor mechanism, that's a huge problem. And I think we can all agree upon that. So
no doubt,
that's more my patient population is like, that's who gets referred to me. And I think I'm scarred by that. Because there's no great solution for that, right? And I mean, it's a horrible situation for the patient.
I've had a couple situations recently, and I don't know how this has happened recently a couple times, but it has. People have come to me with chronic quad tendon ruptures that those are just very difficult to deal with. And one guy finally just bit the bullet and did a primary repair augmented with Marlex mesh, kind of like we do in the arthroplasty world. And I really, as aggressive as I am with motion on almost everything, as we're having this discussion tonight, I'm very much on the end of motion. That guy I locked up for a good 2 months. I'm like, dude, you're staying in a cast until this thing heals, because at that point we're in the salvage situation. It's that's of course what we're all trying to avoid, is that person that comes in that either had a missed injury or comes in months later saying, well, I had this fixed but everything fell apart and I was just kind of putting up with it, and now my leg gives out and I fall all the time a year and a half later. You get to that point, it's a tough one, and you have to kind of shift the paradigm in your mind of, how am I getting this from the how do we achieve healing and maximum function, to how do I just give this person a functional leg again, so they can just do daily activities, let alone have normal strength, normal motion, all that kind of stuff. So yeah, I think we're all on the same boat, on the same page there, that's what we're trying to avoid.
Yes.
So Jan, so far we've been talking more about the traumatic and acute patella fractures and how those are fixed. Can you run us through the other type and more of the patella stress fractures and how you manage those when you see them?
Yeah, so I've only seen a couple of these, and I think it's just the location where I work in terms of a trauma center. They're not usually coming into the trauma center with a stress fracture. When I have seen them, it's usually like they complain of, anterior knee pain, and when on history, like it is something like, I've been training and I have knee pain. They come through the walk-in clinic, and then you start asking them questions, and I'm training for a marathon. I used to see it in my previous practice where I used to take care of a lot of more active military patients. And they get stress fractures everywhere. Wherever you think you can get you even didn't know you could get a stress fracture in a certain bone, they would get one. And you're like, okay, that's the first time I've seen this. And you do a Google search or a PubMed search, and you're like, oh yeah, military, someone in the military has this. So, that's what I'm thinking. Most of the time it's an overuse injury. For me, I've never done surgery on one yet, knock on wood. I mean, I've only seen a couple, so I'm sure there's people that have had surgery. Usually, I take them off activity. I do then no impact. They can just do, range of motion activity, like a bike, swimming, something like that. That's just, not going to put a lot of strain across the knee joint. And then I always do a nutritional workup. I have found almost, not every stress fracture, but many stress fractures are somehow related to something, nutritionally. Like, I found one just the other day. It was a stress fracture, and the patient had an issue with their parathyroid hormone. So it wasn't vitamin D. Everybody, vitamin D is the most common one, especially in the Midwest. Like, who's outside today in Indy when it's 11 degrees outside? No one's sun tanning. But another thing is could be other hormone related deficiencies such as parathyroid. You can see it. So that's my whole thing is a nutritional workup for these patients. And then, hey, you got to slow down whatever activity you're doing. This is one where like, does that hurt? You need to stop.
Yeah. I've had a couple of times where we've had to get into some different conversations that we're not normally having about orthopedic surgery with like female athlete triad, where they're, disordered eating, stress fractures, and menstrual irregularities. Not very often that Dr. Benner's talking about menstrual irregularities and menstrual cycles and diet in the office. But there are some times where this does come up, and sometimes it's gotten a little bit emotional for the families and the patients. Sometimes you start digging a little bit into, well, tell me a little bit about what are your diet habits like, because sometimes these fractures can happen in people who aren't getting adequate nutrition, and then the kid looks over at the mom and the mom looks at the dad and everybody looks at and you go, uh-oh, I've touched a nerve here. Pretty soon there's a tear going down the kid's face and mom's got her hand over her head, and now you're into a much deeper, more emotional and sometimes even into the psychiatric realm as well around eating disorders and things like that. So this is where you want to see an orthopedic surgeon get uncomfortable and make us start talking about menstrual irregularities, eating habits, psychiatric issues, things like that. But it's definitely a part of the picture when you're talking about young athletes, repetitive use athletes, runners, people who do repetitive jumping sports like this that really have everything wrapped up in their sport and end up with a stress fracture. I've only seen a couple stress fractures of the patella, but they are tension side stress fractures in that usually it's on that anterior cortex where you start to see a little bit of gapping anteriorly, and that's a high risk stress fracture, kind of like femoral neck and other places where those are tension related stress fractures that have a high risk of non-union. So I've only fixed one of these when I put a couple screws in, and I actually put a cable in as well so we could still maintain motion during that time while it was healing, and knock on wood, she did really well. But the other couple of them that I've seen have been in kind of weekend warrior type athletes, people in their 30s and 40s who said, yeah, I just took up basketball. I've been playing, 2-3 hours, 4 times a week. All of a sudden, that, and I have some pain in that area. That it's been more like, the patients are like, I'm not that kind of an athlete. I'm not in any rush to keep doing all this stuff or, maintain that level of impact. I'll just throttle down for a while and we'll see if we can get it to heal. And we have most of the time. It's just really the one that I can remember. And in that one in particular, some of the difficulty with diagnosis was she had been told that she had patella tendonitis because she was a volleyball player. Almost every volleyball player I've ever taken care of has some amount of patella tendonitis, and it's a centimeter, an inch away from the where they usually have patella tendonitis. So it's very easy to say, well, lots of volleyball players have patella tendonitis. That's probably what it is. We don't need an X-ray. We deal with this all the time, and that's what happened to this kid. By the time she came and saw me, it had been going on for a longer period of time. Got an X-ray, had a stress fracture. We ended up having to fix it. So that's something that taught me, luckily from someone else's mistake and not my own mistake in that situation, to always think about patella stress fractures whenever you're thinking about patella tendonitis and repetitive jumping athletes.
So now that we've talked through a variety of scenarios here, can you talk a little bit about what type of outcomes we're seeing in 2025 and how that relates to the conversation you're having with the patient when it comes to expectations?
Yeah, so for me, the outcomes, I start having that discussion when I see them preoperatively, what potentially they can expect. And I think that's where the CT scan also helps me, because if there's a lot of comminution on a CT scan, or I kind of correlate comminution with cartilage damage, I tell them that long term, they can get more post-traumatic arthritis. In the short term, I've not seen it. I've not, luckily, I've not seen like rapid progression of arthritis after a patella fracture. But, we see patients later on who have had injuries who obviously have bad patellofemoral disease, that are showing up with knee pain years down the road. So I do let them know that, they can, I have no restrictions for them. Once they heal, I don't restrict them from any activity, but I tell them the whole recovery is about at least 6 to 9 months, if not longer. And a lot of that, and it has to do, in my experience with the just muscle atrophy of that leg, right? They get a lot of quad atrophy, a lot of, calf atrophy, and it just takes time to get back to whatever activity they like, especially if they're more mature in their age. If they're younger, I think they can get back in that 6 to 9 months. Otherwise, I think they're taking about a year to get back. But I tell them about arthritis, but I don't know. And this is one question for Rodney. How many patients are you seeing with bad patellofemoral arthritis who are getting total knees who've had a previous patella fracture that was operated on?
Almost none, to be honest with you. I don't know that I've had many patients, if at all, that are coming to me for arthroplasty procedures saying my knee was fine until I had a patella fracture 5 years ago or whatever, and now they have a normal tibiofemoral joint, but have isolated patellofemoral arthritis that are having surgery. You just don't see it. So I'm with you there that while it does have the potential to lead to problems down the road with post-traumatic arthritis, it's not something I see very often. So yeah, I'm with you there. And do you really have any trouble with healing with these? I don't feel like this is necessarily a healing problem most of the time.
Yeah, not really. I mean, I've had like one non-union that I know of myself. I've also seen, though, sometimes the patient will be sent to me with a quote non-union of a patella fracture, totally asymptomatic because they've healed everything around it and there's nothing to do then. So I have seen that. The one thing that I would say is probably the most common thing I see post-op at a longer term, 6, 9 months, or even a year out, is some type of hardware irritation.
Symptomatic hardware, absolutely.
They feel the screw that you put in, they feel the plate that you put in, they don't like it, something like that. But otherwise, most of them do heal, like thankfully, right? It's very rare, I think, to see a patella non-union just because of the vascular supply.
Yeah, I've taken out wires, and I've taken out K wires and tension bands. I've taken out 2 plates off the same patient. She actually broke her patella, had it plated, broke her other patella, had it plated, and then it came back in a staged fashion. And I took her hardware out on both sides, which both of them luckily made her better. But I don't think I've ever taken out hardware in people who had screw fixation. That's the one that maybe the wire gets them a little bit, but the screws are usually not, I guess. So that's I was shocked the first time I saw a plated patella, like, holy crap, that's a lot of hardware for a patella. If the old trauma thing, you put enough hardware in there, you can't tell if you malreduced it or not. Just keep putting screws in. Very good. Well, any other comments, Jan, before as we wrap up here? It's been a good discussion about this, and I think a lot of good learning points for people who listen. Anything else that we haven't covered, or any kind of take-home points that you have for our listeners about patella fractures?
No, I think we covered most of it. Thank you for, having me on, for you and Scott. I think one of the take-home messages I got is, maybe with, the therapy post-operatively, maybe to be a little bit more aggressive, to get a little bit more early function. Because that's one of the biggest complaints I've seen from patients is that, when they're immobilized, it really changes their life, right?
No doubt.
Whether they go to the bathroom, I don't have them wear the brace in bed, but even going to the bathroom, showering, bathing, it's much more difficult. So maybe you can give them back a little bit more freedom, getting it in and out of a car. I think, I got to be thinking about this, because I'm more confident in the fixation. So if I'm more confident in fixation, maybe, push that a little bit more with from a therapy standpoint. So I think
definitely if we're going to increase the amount of fixation we have, we should definitely try to couple that with how can we be less restrictive in the early time after surgery, and not necessarily tell the patient, unfortunately, you're just going to have to live with some flexion loss and some quad weakness, and that's the end of the story.
I just blame the therapist.
That's all the time, right?
We get blamed for everything. If
anesthesia's not around, somebody's got to be blamed, right?
You probably blame the surgeon then, right, Scott? You're like,
absolutely.
It's clearly not our
They
fault.
screwed that one up. But I think that is, if you ask me about a lot of things in orthopedics, about what do we need to do differently? What's the thing that's missing? For me, it's very rarely we need better fixation, we need better alignment, we need better techniques, we we need better implants. From my perspective, as working with a lot of people in sports medicine, and then applying those lessons that Dr. Shelbourne's taught me over a lot of years to my arthroplasty practice, it's how do we be as aggressive as we possibly can with the physical therapy without causing problems? And that middle ground is the hard part when it comes to trauma of where that middle ground is. So I think that's important as we change fixation techniques, that we definitely couple that with how do we get better from a rehab perspective.
Yeah, and I think one of the things, it's like you kind of, I mean, it's probably case in point, a podcast like this where you have your co-host is a physical therapist as well.
Yeah.
I think that's very, enlightening, I would say, probably in your practice and just in these kind of types of conversations, because I mean, everybody sees things from their silo, and that's not a good thing. So
I can tell you, so Dr. Shelbourne's been really focused on ACL surgery, athletic knee injuries for the longest time. And then when I came around with joint replacement, increasing our joint replacement volume, sometimes there were patients that were struggling with early extension, for example, and the therapists were like, what is going on? Something's wrong. This is not okay. Like, this patient's got a 5-degree flexion contracture 3 weeks out. And I'm thinking, so what? That's, they were 10 last week. They're 5 this week. They'll probably be straight next week. And it took a while for us to figure that out, of the different perspective of the arthroplasty surgeon versus the sports medicine surgeon. I learned that I had to change some things technique wise to try to improve their early extension. And the therapist had to learn, well, maybe early extension isn't such a big deal in total joint replacement like it is in the ACL world, that if somebody comes back with a 5-degree flexion contracture at 1 week, and then 3 degrees at 2 weeks, and 1 degree at 4 weeks, and full extension by 6 weeks, maybe that progression's a little more predictable than they thought. And I know in particular, I had to think about distal femur resection, for example, in that discussion of, maybe I need to get 10 or 11 millimeters of resection instead of 8 or 9, and be mindful of getting that distal resection to where they could get straight more easily, and trying to have that kind of, interrelated discussions with therapists. One of the first episodes we did on this podcast was interdisciplinary care in orthopedics, and I've learned a lot from them about how to make things better from a rehab perspective, and I feel like they've learned a lot from me on differences between sports medicine versus arthroplasty and joint replacement, and that's been a good marriage there. So, the more of that we can put into the trauma world, I think as well, getting your perspective as a trauma surgeon, my perspective is more of a reconstructive surgeon, and Scott's as a researcher and physical therapist. That's where the rubber meets the road, and we still to really maximize things for our patients. So Jan Szatkowski from MyU Health, Director of Trauma, thank you for joining us tonight. It was good catching up with you as always, and hopefully we'll have you on again sometime in the future to talk about other topics.
Absolutely. Nice meeting you, Scott. Thanks, Rodney.
Very good. Well, if you want to catch us on social media, you can find us on Facebook and YouTube at the Shelbourne Knee Center podcast pages. You can find us on Twitter and Instagram at the SKC podcast. If you have any questions, email us or catch us on social media. Our email address is the skcpodcast@gmail.com, and we will see you again next time. Thank you for joining us on the Shelbourne Knee Center podcast.